All right, sorry, good. I think we'll just start now. Um, so okay, so today's session is on pituitary embryology, neuroendocrinology, and neuroendocrinology, corticosteroids, and hypothyroidism. So essentially, the posterior pituitary and the anterior pituitary are from two different parts of the developing fetus. The anterior pituitary essentially is it's called the adenohypophysis, and it's from the ectoderm of the oropharynx. Is downwards evagination of the epithelium of the ectoderm of the oropharynx, and this develops from what is called the Rathke's pouch. Eventually, it goes downwards and settles within the sphenoid bone, and then it separates then it becomes separated from the oropharynx. That's the from of this particular oropharynx. It gets separated as it descends downwards. Eventually gets separated, and then the oropharynx moves posteriorly, with further development of the diencephalon and then subsequently the telencephalon. So pushing the oropharynx downwards and posteriorly. Um, the in cases, sometimes the rat case pouch, which parts of it, rat case duct or pouch, may remain, forming a craniopharyngeal duct. And sometimes it may also form a rat case pouch cyst. Or some cases, remnants of it have been seen in certain patients to develop into has been postulated to develop into craniopharyngiomas. Um, the posterior pituitary is a downward continuous um, is a downward continuation of the hypothalamus. Downward evagination of neural crest cells from the floor of the third ventricle and the residual recess in the floor of the third ventricle called the median eminence. Essentially, it's just a continuation of the brain from the median eminence, which which continues downwards. Um, yeah, essentially, I think basically that's it. I don't know if anyone has any particular contribution. Let's make it now before I proceed to the other parts. So, in absence of any contributions, we'll just move to the next part to discuss the anatomy of the pituitary gland in relation to the hormones that are produced there. So generally, the pituitary gland produces eight hormones, six from the anterior pituitary and two from the posterior pituitary. The anterior pituitary is one of the only two sites in the body that has a portal circulation, of course, one in the liver and the other one in the anterior pituitary. Um, the the tuber cinereum of the hypothalamus releases the six certain hormones in a pulsatile fashion, right? And they terminate and they are conveyed via the hypophyseal, that's the portal system, to their terminus in the median eminence of the pituitary stalk. These hypophyseal hormones are then released into capillaries of the hypophyseal portal circulation, which carries them to the pituitary stalk to a second capillary bed in the anterior pituitary where they control release of hormones by the adenohypophyseal gland cells. So essentially, they are releasing hormones. They are release hormones that are produced from the hypothalamus, and then um, they are then subsequently um, control the action. They then control the action of the anterior pituitary, essentially. So, and then the posterior pituitary, of course, is a direct continuation of the hypothalamus. So cells, the hormones, antidiuretic hormone and oxytocin are synthesized in neuroendocrine neurons. They are called magnocellular neuroendocrine neurons in the supraoptic and paraventricular nuclei of the hypothalamus and are conveyed along their axons in the supraoptic hypophyseal tract, also known as the pituitary stalk, to the posterior pituitary where they are released into the circulation. Now, the complete homeostatic loops, including a negative feedback involving the hypothalamic hormones. Anyway, this is a different, is an interesting pathway. Of course, we all know the hypothalamo pituitary adrenal axis and all those various axes, hypothalamo pituitary gonadal axis, and the various axes that are involved in control of positive and negative feedback relationships between the hypothalamus, the pituitary gland, and then the effector organs very rarely. Also, of course, the thyroid gland. Yeah, so propionate is the first hormone that was described in the text. The 241 amino acid polypeptide is the hormonal precursor synthesized primarily in corticotrophs. Um, Yeah. So it's primarily in corticotroph cells of the anterior pituitary, but also in found the hypothalamus. It contains amino acid sequences for aminocorticotropic hormone, melanocyte stimulating hormone, the alpha, and then beta lipotropin and gamma lipotropin and beta endorphin and methenkephalin. So of course, majorly the most important ones are the the ACTH, melanocyte stimulating hormone, which has been implicated in pigmentation, uh, um, and then beta endorphin and methenkephalin. Of course, beta endorphin and methenkephalin have been implicated in as synthetic opiates, or what they call them now. I say synthetic opiates, endogenous opiates. Yeah. So I don't know if anyone has any question. Let's just contribution. Let's make them now. All right. So I guess there's no contributions. All right. So we'll move on to. So anyway, the most important thing is that pure melanocortin is like a mega hormone that is usually spliced to produce these other ones. about six hormones within the megastructure, and it is located. Some people say it's located in the intermediate part of the pituitary because, of course, the pituitary gland, they say, is divided into three parts. We have the anterior pituitary, intermediate, and posterior pituitary. Of course, we all know that anterior and intermediate are essentially one gland, which is the anterior pituitary. So part of the anterior pituitary is part of these cells are in sorry, the anterior pituitary, and they produce POMC. Of course, the other cells, or the cells of the pituitary are divided into various forms of various names. There's there's the alpha cells, I think the beta cells, and then also the gamma cells. Um, they produce different hormones depending on their functions. Um, just trying to remember. It's been a while I read this pathophysiology, but essentially the I think the alpha cells are the ones that produce growth hormone. Then I think the gamma cells or beta cells now produce I think ACTH and not thyroid stimulating hormone, I think TSH. Yeah, TSH, I think. And then the gonadotropins are also produced by certain other groups of cells. I can't exactly remember, but I think that's how it is. Um, the so essentially here, so ACTH is synthesized from the POMC, and it's the first 13 amino acid terminal of its sorry, they are produced is produced as part of the hormone complex within POMC. Now, it's said that the first 13 amino acid of ACTH are identical to alpha MSH. That's the melanocyte stimulating hormone, and the active half-life is 10 minutes. It produces a diurnal peak in the cortisol. Highest peak occurs in the early hours of the morning, the second lesser peak in the late afternoon, and also increases in response to stress. The control is from corticotrophin releasing hormone from the hypothalamus, which stimulates its release, especially when the levels of ACT has a negative feedback effect. When the levels of ACTH rise, TRH levels decrease, and then ditto with the levels of ACTH with peripheral levels of cortisol or the adrenal hormones. When their levels increase, they elicit a negative feedback effect on ACTH action, which drops its levels. And then subsequently, of course, opens the gate for CRH to be released after some time. And then, yeah, so the diurnal rhythm is established in that manner. Prolactin is also called somatomamotropin, is a 199 amino acid protein, weighs 23 kilodaltons. The levels are higher in females than males and are still in pregnancy. Prolactin is secreted in a pulsatile fashion with a frequency and amplitude that varies during menstrual cycle. Approximately 9 pulses in a 24-hour period in the luteal phase. And the late follicular phase is about 14 pulses in 24 hours. Okay. The pulse amplitude increases from early to late follicular and luteal phases. There's also a diurnal variation. Levels begin to rise 1 hour after the onset of sleep, and it peaks at 5 to 7 a.m. And then there's another, there's a trough in mid-morning after waking up. Heterogeneity of the molecule may produce different results between bioacids and amino acids. Prolactin is the only pituitary hormone predominantly under inhibitory control from the hypothalamus by prolactin releasing inhibitory factors, with dopamine being the primary PIF. Prolactin releasing factors include thyrotropin releasing hormone, also active intestinal peptide. Physiologic role of the releasing factors is not established. All right, so essentially it only acts, it's the hormones from the anterior pituitary, um, sorry, from the hypothalamus that control the action of this of prolactin is the hormone that controls its action essentially is majorly dopamine, which is the primary PIF, that's prolactin inhibitory factor or prolactin release inhibitory factors. However, there are prolactin releasing factors whose function is unknown. That's essentially what they're trying to say here. Yeah. Any question? Okay. So essentially, we're almost done with the hormones from the pituitary. The next is the growth hormone. Um, suffices to say that prolactin's function is in lactation, helps to um, um helps with maturation of the mammary glands and aids production of breast milk, lactation, um, breast development and lactation, essentially in females, particularly in females. Um, the major hormones that are responsible for breast development in the sense of formation of the alveoli and the acinar glands and all that that are involved in breast development are actually um, majorly estrogen, which is involved in the fibroglandular development, then progesterone, which is involved in majorly the glandular development, especially during menstrual period and pregnancy. However, prolactin is required for milk production. So it helps to activate the action of the breast as a gland, as what prolactin does. Then, of course, we know oxytocin is involved in milk letdown. So there are four hormones essentially that are involved in lactation. Um, Estrogen and progesterone are involved in breast development. Prolactin in initiation of lactatory function of the breast, and then oxytocin involved in letdown of milk. Um, yep. So yeah, the functions of these hormones. We've already talked about the um, corticotropes. Of course, we know the anterior pituitary. I'm sorry, the anterior pituitary ACTH is produced. It goes to the adrenal gland, activates cortisol production. Cortisol production. Cortisol, of course, helps with homeostasis, stress response, endogenous steroids, and all those are various functions of endogenous steroids, metabolic activity, immune function, and immunomodulation, and all that the cortisol does. Of course, we know it works hand in hand. Is glucocorticoid, glucose production, stress hormone, activation of the glycolytic pathway, and various other glycogenolysis and all those other pathways that are involved. Essentially, um, and then it also has a mineralocorticoid-like effect, especially when its levels are high. So it can cause sodium excretion and potassium retention. Anyway, so then okay, so then we can go to the time growth hormone. Yeah, so growth hormone is a 191 amino acid polypeptide. 191 amino acid polypeptide trophic hormone. Um, Also secreted in postal fashion. The prolactin has prostatality, is particularly affected by menstrual cycle, as we said earlier. However, growth hormone's postal production is 5 to 10 pulses 24 hours, primarily at night, up to 30 micrograms. Levels may be undetected um, when it is assayed between pulses. So the protein, the effector factor that like the substance within the bloodstream that actually affects the action of of growth hormone is actually the IGF-1 or somatomedin C. It has insulin-like growth factor 1, also known as somatomedin C. And this is produced in the liver in response to growth hormone action. Um, Growth hormone acts directly on the epiphyseal plates of long bone to stimulate chondrocyte proliferation. And of course, its action is affected by gonadotropin releasing hormone. And I think there's also an inhibitory substance. Yeah. Anyway, um, the arcuate nucleus sometimes stimulates pituitary secretion and strength of gonadotropin and induces growth hormone gene transcription. Somatostatin also, yeah, somatostatin is the inhibitory peptide. So somatostatin is the growth hormone inhibitory hormone, and it is produced from the periventricular nucleus, and it suppresses growth hormone release only. It has no effect on its synthesis. So growth hormone release is also stimulated by ghrelin, which is produced in the GI tract in response to certain nutrients. It may act partially or totally via hypothalamic growth hormone releasing hormone. So essentially, that's the control and the diurnal variation and all that. Of course, we all know that availability and excess of growth hormone results in what is called the um, what's called acromegaly in adults, and in children it causes gigantism. Right. So, and then lack of it causes dwarfism, pituitary dwarfism. Okay. I don't know if anyone has anything to add right now. Anyone? Want to add something? Okay. Let's proceed to let's proceed to thyroid stimulating hormone, right? So thyroid stimulating hormone is a glycoprotein trophic hormone secreted by thyroid cells of the anterior pituitary. Its action is actually controlled by somatostatin, which inhibits the release of thyroid stimulating hormone, and thyroid releasing hormone, thyrotropin releasing hormone, which stimulates its production. Both of them are from the hypothalamus. Um, Thyroid stimulating hormone acts on the thyroid gland, stimulates the production of thyroxine and T3, of course, triiodothyronine, which acts peripherally in regulating basal metabolic rates and also involved in growth and organ development. Um, the lack of TSH can result in cretinism in children. Yeah. And then in adults, it can cause hypothyroidism, excess action, as in either autoimmune activity or high excessive can result in hyperthyroidism. Various other, of course, clinical correlates to this, and a lots of relationship between the hormones and all that can actually affect the levels of TSH and pituitary activity of TSH. Yep. So the next is gonadotropins. Gonadotropins are two. We have follicle stimulating hormone and luteinizing hormone. And they are released from the anterior pituitary in response to gonadotropin releasing hormone action. Synthesized primarily in the preoptic area of the hypothalamus. And the most important thing about these hormones is that they are important in fertility. Sex hormones stimulate the gonads um, in production of testosterone, estrogen, and progesterone. They are also involved in um, maintenance of menstrual cycle in women through the positive and negative feedback effects they have. Breast development, uterine development, formation of secondary sexual characteristics, sexual development, all benched on these hormones. Yep. All right. So the next is antidiuretic hormone. So we're now in the posterior pituitary. Antidiuretic hormone, also known as arginine vasopressin, and the major source of this hormone is the magnocellular portion of the supraoptic nucleus. So just give me a minute. So if anyone has any contribution, please make them now. All right. So the next is I think I was talking about antidiuretic. Apologies, I'm actually on call, so I've been getting a lot of calls tonight. I just have to do this stuff so that I can move on. So antidiuretic hormone, um, yeah, it's produced by the magnocellular portion of the supraoptic nucleus of the hypothalamus, and it's conveyed along axons in the supraoptic hypophyseal tract. Of course, that's the pituitary stalk. To the posterior pituitary gland, where it's released into the systemic circulation. All its actions result from binding to hormone-specific membrane-bound receptors on the surface of target cells. Of course, these cells are called the V cells or V2 receptors. One of the major effects of ADH is to increase the permeability of the distal renal tubules in increased absorption of water. Of course, that's the distal convoluted tubule and the collecting ducts. They have the V2 receptors on their membrane. And when this is stimulated, it results in production of certain proteins within the cell membrane of these cells called aquaporins. And these aquaporins increase the permeability of the distal convoluted tubule and collecting ducts to water, to free water actually, and then allowing reabsorption of free water from the tubules into the bloodstream. So that's why you have what is called the antidiuretic hormone, because it decreases, it concentrates the urine by reabsorbing water from the circulation. And of course, the most powerful physiologic stimulus for its release is an increase in serum osmolality. Yeah, so in order to allow, and this is because, and then a less potent stimulus is a reduction in intravascular volume. So ADH is released in glucocorticoid, also in patients with glucocorticoid deficiency. In order to be able to compensate, it's also released. And then exogenous glucocorticoids inhibits its production. So patients that are on steroids may have reduction in ADH production. Of course, it's also a potent vasoconstrictor. The aim is to help increase vascular volume, intravascular volume, and decreased fluid loss. So that's why it's a potent vasoconstriction. It's important in patients that are dehydrated or have shock, fluid loss. Of course, we know the clinical correlates for ADH is in patients with either SIAD, syndrome of inappropriate ADH hypersecretion, or diabetes insipidus, which can be central or nephrogenic. Of course, for us, most important is in DI, where, and anyway, SIAD too, because of brain tumors that actually have inappropriate ADH hypersecretion or from trauma. Most importantly, DI, especially in patients who have undergone pituitary surgeries, have or skull-base hypothalamic surgeries or third ventricular surgeries may develop diabetes insipidus, clinopharyngiomas, and various other conditions that are around the cellular region, result in DI, essentially. The last one is oxytocin. Because oxytocin is a neurotransmitter as well as an hormone, particularly hormone in the sense that it's involved in breast milk letdown reflex, as I said earlier, and also very important for uterine contraction during labor because um, towards term, the uterine muscles become quite sensitive. There's oxytocin receptors on the uterine muscle walls, and then becomes sensitive, particularly sensitive to oxytocin, and then helps in affecting labor along with other things like prostaglandins and various other substances. Yeah, so essentially these are the hormones of the pituitary. And if we have any contributions, let's make them before we go to corticosteroids. And, I think the last is corticosteroids. So I just wanted to check the schedule to know what's the last one we're taking tonight. Okay. Corticosteroids and hypothyroidism. Okay. Okay. Ooh, still have a long way to go. Okay. Right. So corticosteroid under normal basal conditions, this okay, yeah. So the adrenal gland has three parts. You have the zona fasciculata, zona glomerulosa. No, sorry, first is zona glomerulosa, followed by zona fasciculata, and then, of course, the last is zona reticularis. Zona fasciculata is involved in production of zona glomerulosa is involved in production of the mineralocorticoids, which includes aldosterone. And then you have zona fasciculata, which is responsible for production of glucocorticoids, which includes cortisol and cortisone. Of course, the most active one of both of them is cortisol. Then the third level is where you have production of sex steroids, but not particularly the most important ones though, because majority the glands, the estradiol and then oxyprogesterone or something like that are produced from that level of the adrenals, but the major ones are produced from the gonads. So corticosteroids are produced by the zona fasciculata, and then about 15 to 25 milligrams per day cortisol is produced. From there, the others are actually, and then 1.5 to 4 milligram of corticosterone. The others, cortisol in the body are actually produced from fat cells peripherally. Cortisol has a half-life of approximately 90 minutes, and the release of cortisol by the adrenal gland is stimulated by ACTH, which is in turn stimulated by CRH from the hypothalamus. We've all talked about this earlier. In primary adrenal cortical insufficiency, that's Addison's disease, both corticoids and mineralocorticoids are deficient and must be replaced. So in secondary cases, it is usually from ACTH deficiency. Yeah, so mineralocorticoid secretion is usually normal. Only glucocorticoid needs to be replaced. And that's an important one. Of course, whenever you have a gland and they say primary, it means that it is the effector gland that has the problem. But when it is secondary, it means that it is the stimulating or inhibiting gland that has the problem. Say, for example, if they say primary hypopituitarism, of course, it means that the problem is from the pituitary gland. But when it is secondary, it means the problem is usually from the hypothalamus or any other structure or any other thing that may have direct effect on the hypothalamus, but not, sorry, I said on the pituitary, but not from the pituitary itself. So primary hypogonadism, the gonad problem, but secondary hypogonadism is usually a pituitary problem or from any other thing that may affect the gonads. So essentially, that's really how it is in endocrinology. Um, Going forward, um, so we'll talk about the equivalent steroid doses. I think we should just look at this table at our convenient time. Equivalent corticosteroid doses and potency of them. Physiologic replacement in absence of stress can be accomplished by placing the patient on hydrocortisone of 200 milligrams orally, AM and 10 milligrams PM. Sorry, 20 milligrams AM, 10 milligrams PM. That's physiologic. Prednisolone 5 milligrams AM, 2.5 milligrams PM. That's physiologic dosing. Cortisol and cortisone are usually useful for chronic primary adrenocortical insufficiency or for addictions crisis because of mineralocorticoid activities and used for chronic therapy for other conditions like hypopituitarism may result in salt and fluid retention, hypertension, and hypokalemia. Yeah, because so prolonged use is not really good. So you have to balance it out. Because the problem is that most of the time, if you give, as I said earlier, cortisol has mineralocorticoid activity along, while those adrenocortical hormones they don't have glucocorticoid activity, but cortisol can act. So if one has a primary adrenocortical problem, yeah, the giving cortisol alone may suffice for the patient initially. Of course, one may eventually have to compensate with fluorocortisol, which is an mineralocorticoid. But initially, yeah, you can actually give cortisol because it has both glucocorticoid and mineralocorticoid action. It can act on the kidney. However, if the patient has a secondary hypopituitarism, secondary cause like hypopituitarism, because it may have over accentuate the mineralocorticoid action and then result in features of hyperaldosteronism, like fluid, sodium and water retention, and hypokalemia and elevated blood pressure. And that's what this last line means. I don't know if there is any question at this point. Please ask questions, make contributions, please. Okay, but am I audible though?
Yes, you are very clear.
All right, perfect. Okay, so next is hypothalamic pituitary adrenal axis suppression. Chronic steroid administration suppresses the hypothalamic pituitary adrenal axis and eventually causes adrenal atrophy. Yeah, so when this axis is suppressed and you suddenly stop administration of the exogenous steroids, the patient can suddenly deteriorate. And this is because um, long-term exogenous steroid administration will result in a negative feedback on the pituitary gland, thereby suppressing production of ACTH production. This will also result in a reduction in stimulus to the zona fasciculata and reduction in production of steroids. So the problem here is that when this happens, because these hormones, they are actually not just stimulating, they are actually trophic to the glands, meaning that they stimulate the glands proliferation so that helps the gland to produce more cells and all that. So after a long time, if you don't stimulate those glands, they will atrophy. So that's what happens here. Adrenal glands will become atrophic, and then when you withdraw the exogenous steroid, what happens is that the patient will now develop sudden Addisonian crisis because of adrenal insufficiency. So you may have to just so if one wants to stop exogenous steroids administration, you have to taper your steroid withdrawal in order to prevent development of Addisonian crisis. Yeah. All right. So essentially, that's what this paragraph means, and these are the features: fatigue, weakness, arthralgia, anorexia, nausea, hypotension, dizziness, hypoglycemia, dyspnea. Because the patient can go into circulatory collapse, hypotension, shock, and that's the Addisonian crisis. So you may have to administer high dose corticosteroids plus or minus fludrocortisone to help the patient recover and fluid resuscitation. Yeah. Okay. So next is so here they're talking about the suppression depends on the specific glucocorticoid used, the route frequency, time, and duration of treatment. Suppression is unlikely if you give less than 40 milligram prednisolone in the morning for less than approximately 7 days, with every other day therapy of less than 40 milligrams for approximately 5 weeks. Some adrenal atrophy may occur after 3 to 4 days of high dose steroids, and some axis suppression almost certainly occur after 2 weeks of 40 to 60 milligram hydrocortisone daily. After a month or more of steroids, the HPA can be suppressed for as long as a year. So measuring morning plasma hydrocortisone can evaluate the degree of recovery of basal adrenocortical function, but does not assess the adequacy of the stress response. So I think this is one thing we need to be careful about, especially as surgeons, because we give a lot of neurosurgeons, because we give a lot of steroids to our patients, especially those who have brain tumors, and we're trying to manage vasogenic edema, all that. So it's important to note this. All right, so steroid withdrawal. So here they're talking about some of the things I mentioned. So this is the staged. So in addition to the above dangers of hypercortisolism in the presence of HPA suppression, too rapid taper may cause a flare in the underlying condition for which steroids were prescribed. When the risk of HPA suppression is low, as is the case with such short courses of steroids for less than approximately 5 to 7 days, generally prescribed for most neurosurgical conditions. Abrupt discontinuation usually carries a low risk of AI. But if you give it for up to 2 weeks of use, steroids are usually safely withdrawn by tapering over 1 to 2 weeks. So if you give it for 2 weeks, you have to try and taper it for about 1 to 2 weeks. For longer treatment, or when withdrawal problems develop, there's a conservative taper, and this is it in 3 steps. Make small decrements equivalent to 2.5 to 5 milligram prednisolone every 3 to 7 days. Patient may experience mild withdrawal symptoms of fatigue, anorexia, nausea, orthostatic dizziness. Then you backtrack if any of the following occur: exacerbation of the underlying condition for which steroids are used, evidence of steroid withdrawal symptoms, as we've discussed earlier, intercurrent infection or need for surgery. So you may have to give stress doses in those situations. If any of these 3 occur, then you have to go back. But then, once you get the physiologic dose of the glucocorticoid you have been given, then you now switch the patient to hydrocort AM, and then and it said that you shouldn't give long-acting preparation. And after approximately 2 weeks, you do the patient's morning cortisol level, and then you taper the hydrocortisone by 2.5 milligram weekly until you get to 10 milligram. So you're starting from 20 milligrams. So you now taper it, begin to decrease it until you get to 10 milligram. And then every 2 to 4 weeks, you measure AM cortisol level until the ATM cortisol is greater than 10 mics in 100 mils, indicating return to baseline adrenal function, and you can withdraw the steroid completely. So when this return of basal adrenal function occur, daily steroids are stopped, but you must give stress doses when the need arises. And then, of course, you can do synactin test. Check the synactin test of the patient until it's normal. The risk of adrenal insufficiency usually persists for 2 years after cessation of chronic steroids, especially the first year. All right, so essentially that's it. So then the next is stress doses of steroids. So this is also important in patients who have been on long-term steroids and you want to do major surgery for them. Particularly if you're going in for a brain tumor surgery, you want to do patients who has maybe a GBM and all that, and you want to go and operate. You need to give stress doses of steroids prior to going into theater because of the risk of development of um, adrenal insufficiency intraoperatively, which is dangerous. So I don't know what's our practice here. They are saying you give 250 to 300 milligram steroid cortisone per day. Yeah, during physiologic stress, the gland produces 200, 250, 300 milligram per day with chronic corticoid therapy, either at present or within the last 1 to 2 years. Suppression of the normal stress response necessitates supplemental doses. So for mild illness, single dental extraction, just give the daily, double the daily dose. You give 40 milligram hydrocortisone twice daily. For moderate stress, you give 50 milligram hydrocort. For major illness, severe trauma, emergency surgery under GA, give 100 milligram hydrocortisone IV, 6 to 8 hourly for 3 to 4 days until stress is resolved. For elective surgery, there's a guideline here. You can see post-op day 1 up to day 7, AM, PM, and all that. So on the day of surgery, you give 50 milligram cortisone acetate IM followed by 200 milligram hydrocort infused over 24 hours. Now, this is what they give for the cortisol for patients who have been on long-standing corticosteroids, steroid administration. Yeah, side effects of prolonged steroid administration. Of course, the Cushing syndrome and the manifestation. So essentially, that's the major thing here. Cardiovascular hypertension, sodium water retention, hypokalemia, alkalosis, TNS can cause PML, progressive multifocal loop-gain cardiomyopathy, mental steroid psychosis, spinal cord compression from spinal epidural lipomatosis, pseudotumor cerebri, endocrine effect, of course, glucocorticoid function, amenorrhea, Cushingoid fascia. GI risk can result in ulcers, gastritis and stress ulcers, pancreatitis, diverticular formation, impaired wound healing, obesity, friability of the skin, glucose intolerance, of course, hyperlipidemia. Can cause cataract, actually, posterior subcapsular cataract glaucoma. AVN of the neck of the femur, osteoporosis, hematologic hypercoagulability, yeah, immunosuppression, hiccups, and all that. Yeah. So hypocortisolism, renal crisis. I think we really have discussed a lot of this, but the most important thing here is to talk about the administration, the management. So give fluids sufficient for dehydration and shock when these patients come. Give hydrocortisone, sodium succinate, 100 milligrams IV start, then 50 milligrams IV every 6 hours. Cortisone acetate, 75 to 100 milligrams IM start, 50 to 75 milligrams IM 6 hourly. As for glucocorticoid emergency for mineralocorticoid, give deoxycorticosteroid acetate or fludrocortisone, of course. So methylpred is not recommended for emergency treatment. Okay. Yep, I think we are almost done. In thyroid, hypothyroidism. We talked about the thyroid gland and its function. Wound healing to involve the metabolic activity, wound healing, cardiac function, and all that. So in patients who have chronic hypothyroidism, yeah, and then I think this just okay. So to replace, so there is primary hypothyroidism and then there's secondary hypothyroidism. Secondary, of course, comes from the pituitary gland. Primary, which is the main one, may be associated with immunologic destruction of the adrenal cortex. That's Schmidt syndrome. So in patients with adrenal insufficiency, they may also have hypothyroidism, which Schmidt syndrome. So secondary hypothyroidism may present with, may be associated with and may mask reduced adrenal function. The thyroid replacement without adrenal replacement in patients with adrenal insufficiency, as may be seen in hypoparathyroidism, may precipitate adrenal crisis. So we need to give hydrocort over IV over 24 hours in addition to thyroid replacement. Of course, the drug for thyroid replacement is levothyroxine. And you give 0.5 milligrams orally. And then when the patient has been hypothyroid, start at 0.05 orally and increase to 0.025 every 2 to 3 weeks. Okay. Increase by 0.025 every 2 to 3 weeks. For euthyroidism, approximate the dose, follow levels and clinical evaluation. For adults less than 60 years, 0.18 milligrams per day. For elderly patients, 0.12 milligrams per day. All right. So this dose of 0.05 that I mentioned earlier is to prevent myxedema coma. But it's not the ideal dose. For the patient to become euthyroid, you need to give 0.18 milligrams per day for young patients less than 60. And then for greater than 60, you need to give 0.12 milligrams per day. You can also give the patient desiccated thyroid, 60 milligrams, 300 milligrams daily. Okay, so thyroid replacement in myxedema coma. Myxedema coma is an emergency where hypothyroidism and carries 50% mortality, symptoms, altered mental status or unresponsiveness, signs of hypotension, bradycardia, hyponatremia, hypoglycemia, hypothermia, hypoventilation, and occasional seizures may occur. Okay. Treatment. Drugs may need to be given IV because, of course, the patient usually has reduced gastric motility. It's a general supportive care. One has to resuscitate with fluids because of hypotension, hyponatremia. It will correct itself when you give thyroid replacement. So one needs to avoid hypertonic saline in this patient. Hypoglycemia, IV glucose. Symptom of hypocortisolism. Thyroid replacement may precipitate adrenal crisis. So you need to compensate. You also give hydrocortisone along with it. Hypothermia should just use passive warming blankets and warm the patient gradually, and don't rapidly warm the patient, because this can, if one actively warms the patient, to increase the metabolic demand and the patient will now tilt back into hypothyroidism again. Your treatments may not really work. ABG check to rule out hypoventilation, because of course they usually are obese, hypoventilate, they have OSA, obstructive sleep apnea and all that. So IV fluid replacement, IV replacement of the thyroid hormone. We already talked about this earlier, 0.5 milligrams of levothyroxine IV, followed by start dose, then 0.05 IV until patient is able to tolerate orally or arrangement. Can give nasogastric tube, cytomel, which is primarily T3. Yeah. Anyway, so essentially that's it. Any questions, contributions, comments? Please let us make comments. Anyone? Yeah, so today we've talked about the embryology of the pituitary gland. We talked about the various hormones of the pituitary. We've taken some time to talk about corticosteroids production, action, deficiency, replacement, and stress response to them. Talked about hypothyroidism and thyroid replacement and the relationship between thyroid hormone and steroids. essentially, I've just finished talking about myxedema, coma, and how it's managed. All right, and thank you everyone for coming for today's Greenberg session, and have a good evening. We'll continue with the other section.